The topic is ending maternal mortality and morbidity. The time for gender equality is now.
3, go.
Hello, my name is Rosemary Ogu. I'm a professor of obstetrics and gynecology at the University of Port Harcourt. And I'm a consultant obstetrician gynecologist at the University of Port Harcourt Teaching Hospital. I'm an advocate for maternal health, for women's health, to ensure that women do not die when giving birth, during pregnancy and childbirth. The inequality associated with gender is one of the reasons why we continually have women dying during childbirth and delivery. The gender inequality is such that pregnant women are unable to take decisions for their own care because they are waiting for their men. Because they are waiting for their men to be the ones to give consent for surgery. Because they are waiting for their men to be the ones to pay for services. Because they are waiting for their men to provide blood for transfusion. My name is Rosemary Ogu. I'm an advocate for women's health, for maternal health, for ending maternal mortality and morbidity. The death of a woman while bringing forth child continues unabated because of gender inequality. It continues because it is happening to a woman. It is one of the consequences of gender inequality. The time for gender equality is now. It is time for a world with equal ease of access to resources and opportunities regardless of gender. It is time for a world where economic participation and decision making is equal regardless of gender. Sadly, we don't have that yet. Women still depend on men for everything. Let us look at maternal health. The health of a woman while pregnant. Globally, over 300,000 women die during childbirth annually. Antenatal care and delivery with skilled attendants in a hospital could save them. Yet, pregnant women miss antenatal clinic visits because their man is not around. Pregnant women cannot give consent for life-saving surgery because they are waiting for the man to take the decision. So when pregnant women finally present to the hospital on their own, majority of them are unable to provide for themselves. They cannot pay for services. They cannot provide money needed. They cannot provide the money needed for medication, anesthetic drugs, intravenous fluids, and consumables. As a hospital policy, we provide care to everyone presenting with an emergency. Unfortunately, this drains the scarce resources of the hospital and the have stockouts. So we then depend on philanthropists and well-meaning individuals to come to our aid in providing supplies necessary to treat patients. If you'd like to help, we deeply appreciate. Together, we can make things happen. Thank you. We can change the narrative. Now is the time to end gender inequality. We got this scan machine from Australia and it's been helping. Together we can do more. If you'd like to help, please join us. Thank you.
Hi, my name's Emily. And I'm Ellen, and today we're talking about Sustainable Development Goal 5 and its impact on women's health. This goal consists of 6 key targets and respective indicators that we're focusing on today. The first target is to end all forms of discrimination against all women and girls everywhere. To do so, legal frameworks need to be in place. And while progress has been made over the past 25 years, unfortunately, still to this day, women earn only 77 cents for every dollar that men get for the same work. This isn't just an economic issue, but also a health issue. Poor job security and income leaves women to have decreased access to basic, affordable healthcare. The second key target is to eliminate all forms of violence against women and girls. Data from 106 countries show that currently 1 in 5 ever partnered women and girls aged between 15 and 49 have experienced physical and/or sexual partner violence in the past 12 months. This is a critical health issue because it directly relates to an increased amount of injuries, increased mental health illnesses, and increased partner violence also leads to increased pregnancy complications and an increased risk of smoking and alcohol misuse. The third key target is to ensure universal access to sexual and reproductive health. Whilst progress has been made in order to achieve this goal, still barriers exist, with over 20% of countries still having minimum age requirements and requiring third-party authorisation to achieve contraceptive services. If women are unable to access basic contraception, then ultimately their health and morbidity is impacted.
The next target is to eliminate all harmful practices such as child and forced marriage and female genital mutilation. There's been progress in this area with fewer girls being forced into early marriage, and overall rates of female genital mutilation have declined by more than 25% over the last 3 decades. However, progress is still much slower than we would like it to be. And if we want to achieve the 2030 target of ending female genital mutilation, the rate of reduction must increase at least 13-fold of the current rate. The next target is to recognise and value unpaid care and domestic work. Women are spending roughly 3 times more hours a day on unpaid care and domestic work than men. This limits the time available for things like paid work and education, which is only reinforcing gender-based socioeconomic disadvantages. The final target is ensuring women's full and effective participation and equal opportunities for leadership at all levels of decision-making in political, economic, and public life. Whilst there has been some progress, women continue to be underrepresented at all levels of political leadership, and in some countries, such as Papua New Guinea, not a single female holds a seat in national parliament. This massive underrepresentation of women in politics is a major contributor to exacerbating gender inequality, with low levels of decision-making on the part of women in important areas such as sexual and reproductive health issues and many other health issues. More ambitious measures and quotas are needed to boost women's political participation and empowerment. Achieving gender equality requires addressing the structural issues, such as these low levels of political participation. Whilst we've made some progress, we still have a long way to go. And something to be mindful of in this climate of the COVID-19 pandemic is the possibility that the limited progress that we have made could be reversed.
Thanks so much for listening to our talk.
Thanks.
Yes.
Good morning all. My name is Tom Williams and I'll be speaking with my colleague Miss Arabella Rolpar on maternal morbidity and mortality rates around the globe and the impact of the Birthing Kit Foundation Australia. I thought I would take this opportunity at the start of the presentation to define maternal mortality and morbidity. Mortality is the death of a woman while pregnant or within 42 days of delivery or termination of pregnancy from any cause related to or aggregated by pregnancy or its management, but excluding deaths from incidental or accidental causes. Maternal morbidity refers to any health condition attributed to and/or aggravated by pregnancy and childbirth that has a negative impact on the woman's well-being. The most common cause of morbidity includes postpartum hemorrhage, hypertension, and diabetes. The current prevalence of this around the world is ashamedly high. In 2017, approximately 810 women died every day as a result of complications of pregnancy or childbirth, the majority of which, sadly, are preventable or treatable. The brunt of this issue is most felt in lower socioeconomic countries. Of the 295,000 women who died during the following pregnancy and childbirth in 2017, 94% of these occurred in low-resource settings, and the maternal mortality ratio, which is the number of maternal deaths per 100,000 live births, in developing countries remains 14 times higher than in developed countries. With regard to an update on global progress, Goal 5 of the Millennium Development Goals set by the WHO in 2000 was to reduce maternal mortality by 75% and achieve universal access to reproductive health by 2015. While the maternal mortality ratio decreased by 38% between 2000 and 2017, progress has been slow, and the WHO targets have not yet been met. The UN Sustainable Development Goals have now set a target by 2030 to reduce the goal MMR to less than 70 per 100,000 births, but with no country having an MMR more than twice the global average. One of the major factors that accounts for morbidity and mortality in females is infection, which my colleague Arabella will now discuss.
Thank you, Tom. Along with hemorrhage, chronic health conditions, preeclampsia, and obstetric complications, infection is one of the major contributors to maternal mortality, accounting for 11% of maternal deaths worldwide. As Tom mentioned, it disproportionately affects women in developing countries due to poorer access to clean sanitary products. This demonstrates that this issue is largely preventable by provision of improved hygiene. This is where Birthing Kit Foundation Australia, known as BKFA, aims to evoke change. BKFA is a not-for-profit organisation that has been providing a practical solution to improving maternal morbidity and mortality. It does this firstly by partnering with local organisations to address region-specific issues, for example, facilitating discussions around sexual and reproductive health and training local midwives in antenatal care. Secondly, BKFA distributes birthing kits to low-resource countries to reduce infection rates. These kits are assembled by community groups here in Australia and consist of a simple Ziploc bag containing 6 vital clean items: soap, a plastic sheet to place under the mother during birth, gloves, gauze, and string ties and a sterile blade to cut the umbilical cord safely. Our university had the opportunity last year to be involved in this process by assembling 400 birthing kits. These kits are then distributed to a number of disadvantaged countries around the world, specifically to health centres, hospitals, community-based midwives and health workers, traditional birth attendants, and directly to pregnant women. In the 2018-2019 period, over 200,000 birthing kits were sent to 18 countries, the majority going to Nigeria, Somalia, Uganda, and Afghanistan. We hope that initiatives like these will continue to improve the trajectory of maternal mortality and morbidity rates around the world, particularly those due to preventable causes more prevalent in developing countries, such as infection and sepsis. Thank you.
Good morning, everyone. My name is Rose Clark.
My name's Grace Lynch.
And today we'll be zooming in on the #1 cause of maternal mortality around the world, postpartum hemorrhage or PPH. As the burden of this condition is greatest in developing or low-income countries, we'll be focusing on the specific issues associated with PPH in these regions. PPH is defined as a blood loss of 500 mils or more within 24 hours after birth. The global statistics are pretty devastating. It affects around 5% of all women giving birth, and nearly a quarter of all maternal deaths are associated with PPH. In most countries, there are no identifiable risk factors, and is estimated to cause the death of a woman every 10 minutes around the world. Preventing PPH from happening is the best way to prevent mortality and morbidity. The ideal standard of care is known as active management of the 3rd stage of labour, which is the delivery of the placenta. The administration of prophylactic uterotonic medications are drugs that will help the uterus contract, such as oxytocin, should be offered to all women around the world during their 3rd stage of labour. In Australia, most developed countries, if PPH does occur, there are many steps that can be taken to manage the bleeding. The first steps are physical methods, such as uterine massage or bimanual compression. The next step is similar to prevention, giving uterotonic drugs. The final steps involve surgical procedures, such as inserting a balloon into the uterus, suturing it, or even removing the uterus as a last resort. The problem is 99% of maternal deaths due to PPH occur in low and middle income countries. There are multiple obstacles to the implementation of these interventions, which we've described in low income settings, due to resource poor healthcare settings and the degradation of infrastructure evident in many countries.
Some of these obstacles include the cost of uterotonic drugs and surgical implements and the availability of adequate treatment, including difficulties in rapidly accessing surgical facilities in very remote areas. Secondly, storage and transport is a problem. Oxytocin, the first-line drug for the prevention and management of PPH, is a heat-sensitive drug, and requires constant refrigeration to maintain its quality. To implement evidence-based practice, sufficient training of healthcare workers and widespread access to the guidelines for the management of PPH are necessary. Finally, in many of these countries, most women deliver at home without a skilled birth attendant. To combat some of these obstacles, the World Health Organization has identified multiple recommendations for the best management of PPH globally. Firstly, the administration of any safe uterotonic available is recommended for both the prevention and management of PPH. If the quality of oxytocics are compromised due to lack of cold storage, heat-stable options exist, such as carbetocin. Misoprostol is an exciting uterotonic drug as it doesn't require skills in IV administration, so it can be given orally or even self-administered. A recent recommendation is the use of IV tranexamic acid for all women with PPH. It is a drug already routinely used in the management of trauma and major surgeries, so no additional resources or infrastructure in hospitals is required to implement this potentially life-saving recommendation. Despite these recommendations, the mortality rate remains unacceptable because of PPH. More research, funding, and innovation is required to find creative solutions to combat this devastating complication. Some examples of innovative solutions include using two common and cheap items, a condom and a urinary catheter, to create a uterine balloon that can be used to surgically manage PPH. Another is the anti-shock garment that was invented by the military to temporarily reduce bleeding on the battlefield. Finally, there is research into task shifting, ways of transferring the responsibility of managing PPH to community healthcare workers and traditional birth attendants. As you can see, the issues surrounding PPH are complex, and there will be no band-aid solution. It will require systemic change, reducing poverty and improving access to healthcare for women all around the world. Our aim today was to highlight some of the general principles and issues in the management of PPH, particularly in low-income countries. We hope we've raised some awareness of how much work there still is to do in this area and the need to implement protocols that will target equality for all. Thank you.
Thank you.
Hi, I'm Mira Gandhi.
And I'm Jessica Brown.
And today we're speaking about homelessness during pregnancy, specifically the global health services available and the impact of COVID-19.
Women who are pregnant and the homeless constitute a unique group at significant risk of adverse fetal and maternal outcomes. Despite this heightened risk profile, social housing support to this group of women is still less than satisfactory.
A significant proportion of homeless Australians are women, and in 2018 to 2019, 60% of homeless people seeking and receiving assistance from specialist services were women. The largest group of homeless women in Australia are between the ages of 25 and 34. There isn't much accurate data on how many homeless women are pregnant in Australia. However, it is known that homeless women experience higher rates of reproductive health-related traumas, such as unplanned pregnancies, abortion, and miscarriages. Additionally, homelessness is associated with high rates of unintended pregnancy. Homeless women are often forced into sex and engage in survival sex for food, money, shelter, or drugs.
So what is the impact of homelessness on pregnancy? Well, in general, homeless individuals suffer more mental and physical health in comparison to the wider population. Homeless pregnant women are more likely to be affected by acute and chronic health problems, including inadequate weight gain, anemia, and bleeding disorders. There are practical barriers for homeless women to maintaining a healthy diet, including a lack of storage of refrigeration for fresh, healthy food. Experiences of prenatal homelessness cause higher rates of risk factors for poor perinatal outcomes, including low birth weight and preterm birth. Pregnant homeless women are less likely than other pregnant women to attend antenatal care for a number of reasons. Homeless women face barriers to accessing healthcare services, including concern that their baby will be taken from them, lack of transport, cost, wait time, difficulty reading and writing, unsatisfactory relationships with healthcare providers, and a lack of understanding of the importance of prenatal care.
Identified needs of homeless pregnant women include prioritisation of stable housing, support to transition to independent housing, coordination of responses, and, importantly, trauma-informed models of care. Research has shown that homeless women require provision of transport to access prenatal care, and that they prefer a group model of prenatal care. Throughout Australia, there are a range of services tailored towards supporting pregnant homeless women find accommodation and the right medical and government services, some of which we've listed here. There are similar services in America and the UK. However, there is a lack of information regarding statistics and services on homeless pregnant women in Europe, Africa, and Asia. It's predicted that the percentage of pregnant homeless women will be much higher, particularly in Africa, due to forced displacement, which leaves women travelling without food, water, or professional pregnancy services. This is particularly worrying considering Africa has the highest rates of maternal mortality.
So lastly, the impact of COVID-19 on pregnancy. As we know, COVID has spread swiftly around the globe, and governments and public health officials have been urging people to follow aggressive preventative measures, most importantly of which has been to shelter in a safe place. However, for women experiencing homelessness, these measures are quite impossible. Precarious living conditions paired with compromised immune systems, lack of access to adequate medical resources, and the inability to self-isolate put women experiencing homelessness at a significantly higher risk of contracting, transmitting, and dying from COVID-19. So obviously, pregnant homeless women represent a vulnerable group of people who could be better served by a coordinated approach to provision of care to ensure good outcomes for mother and baby. Of note, further research should be undertaken to accurately capture the prevalence of homeless pregnant women.
Thank you.
Thank you.
Okay, so from 2018, myself and Eleanor have been undertaking medical aid work in the Philippines, and we've been doing this in a community in the town of Calauan, Laguna. And this is a community with very poor health outcomes, and for women in particular, there is very low health literacy regarding fertility, contraception, and sexually transmitted infections. And so to address this, a biannual medical clinic was established from 2013, and in particular it delivers a women's health clinic that Eleanor and I have been involved in. And so the focus of this clinic is to deliver through a single visit approach cervical screening, and this consists of colposcopy, but also visual inspection with acetic acid and Lugol's iodine. And from November 2018, we've also been conducting HPV testing. And since 2013, we have screened over 900 women. And we are also to empower the women of this community and to help them to make decisions in the best interests of their health. We've also been delivering education seminars, and those focus on fertility and the menstrual cycle, contraception and the choice to conceive, and HPV and cervical cancer. And we've also been undertaking some epidemiological studies, which I'll now pass on to Eleanor to discuss further.
Great, thanks so much, Oscar. So yeah, as Oscar entailed, since 2013 this project has been run, and as a result, from 7 years of the clinic running, we've accumulated lots of data in terms of risk factors and which women are at higher risk, and again which women are developing cervical cancer. And so I guess I'll get you to move to the next slide. As Oscar said previously, so cervical cancer is the second most common cancer in the Philippines, and it is the #1 cause of mortality in females. And as we know here, most cervical cancers are attributable to HPV, which is why we have the HPV vaccine here in Australia. However, there is no immunisation program in the Philippines. So there are 3 techniques you can use to screen for cervical cancer. There's a cytology screening, the visual inspection, which is used in developed countries, and it's pictured here with the A and the B. So the A is the acetic acid and the B is the iodine. And that is what has been happening in the Philippines in the clinic from 2013 to 2018. However, from 2018, what we introduced was HPV testing, which is looking for the human papillomavirus, which is a precursor for 99% of cervical cancers. So in terms of the study, we wanted to see what the prevalence was of HPV, and in particular, the different strains of HPV. And not only this, we wanted to compare those results to the results that we found with the iodine and the acetic acid. Now, this study is still being conducted, and these are only preliminary results. However, what we have found so far is that
319 patients, so from 2018 to now, have gone through the clinic and have had the HPV screening, and of those, 50 were positive. What we found, which was quite interesting, is while in Australia we mainly get HPV strains 16 and 18, and that is what our immunisation protects against, here in this clinic we found 16, 18, 31, and I'm sure you all can read many more strains. And that's depicted in this pie chart where you've got 18 and 16 making up a real minority, and then HPV 52 actually making up 21% of the HPV strains. So I guess in terms of further research and further development of the study, there still needs to be analysis on whether or not any risk factors are leading to the HPV strains, and not only this, whether or not the iodine and acetic acid screening was detecting the patients at high risk. And so that is going to be looked into further. This is only a preliminary result and just some of the work that we've been doing in the Philippines. Thank you.
Thank you.
Hello to you all. My name is Charles Arcus, and I'm a registrar in obstetrics and gynecology in Sydney, Australia. And I'm very humbled by this opportunity to speak today, and I applaud the event focus on gender equality. As a doctor ready to embark upon a career in women's health, I was fortunate enough to spend time in Papua New Guinea, in the Pacific shores just off the Australian coast, and in both Port Moresby and in the Western Highland province of PNG, I spent some time in hospital with resilient and capable staff who delivered excellent healthcare in the face of inadequate state and health infrastructure. But I also lived with some socially concerned locals who offered me just a glimpse into what sort of impact pervasive government corruption, deep socioeconomic inequities, and entrenched cultural customs can have on the delivery of health outcomes for women. They very much inspired me to pursue O&G as an avenue for health advocacy and made me realise how intimately connected women's health is with the way society and its culture is put together. And so today I thought that I would share some of my observations of my time, and particularly of the barriers to optimising women's health that arise from and extend beyond limited access and inadequate service provision. In PNG, extreme pathology and severe morbidity is driven as much by late presentation and loss to follow-up as it is by a lack of electricity and clean water. This is in part because most people in PNG live in rural areas and find it very difficult to traverse the terrain and leave their community. The roads to town are not well maintained either, and perhaps a metaphor for the struggle PNG faces as it aims to evolve from a nation comprised of many agrarian societies to one that reconciles tradition with Western development. It's difficult to leave home also because many women have large families, limited means to travel, and no reliable income. The city is dangerous too, and many women who reluctantly leave their home are isolated from their tribe and now mixing with people traditionally viewed as strangers. So sadly, this means that many women have unsupervised village deliveries or present to the city hospital with an obstetric emergency in the context of rural isolation and poor Western health literacy. Any interaction care providers have with a woman is thus a precious opportunity to encourage family planning. But counselling appears difficult in the face of the desire to produce a male, expectations for large families who can better cultivate their land, and pressures on women to produce children to honour the financial transaction made at the seal of marriage. Barriers to women's health such as these need urgent but sensitive and thoughtful attention, and as advocates for women's health inside and outside the hospital, may we continue to provide such attention and support those working in challenging circumstances. Thank you.
Hello, my name is Jane McDonnell, and I'm a doctor working in obstetrics and gynecology in Sydney's Royal North Shore Hospital. Australia prides itself on its universal healthcare system, achieving some of the best health outcome measures internationally. However, this good health is not shared equally. Indigenous women suffer poorer sexual and reproductive health outcomes than non-Indigenous women, perpetuating social disadvantage. I performed a systematic review aiming to identify barriers to sexual health and reproductive autonomy amongst Indigenous Australian women. 4 main thematic categories of barriers emerged: The first was vulnerability, sexual coercion, and unbalanced power dynamics. Vulnerability was a major barrier to women negotiating conditions of sexual relationships. Sexual coercion included threats, condom use refusal, and intimate partner violence. Sociocultural norms led to unbalanced power dynamics, where women's roles were seen as reproductive rather than self-determined. The second is health literacy and education. There is widespread lack of knowledge regarding contraceptive options, including emergency contraception, STI risk, and STI transmission. There was low uptake of formal education due to absenteeism and student embarrassment. Resources on sexual health were of limited use due to poor English literacy. The third, system and structural barriers. Structural barriers such as difficulty negotiating the health system, transport for women in remote areas, and lack of culturally sensitive or female health workers undercut the provision or uptake of health services. For women travelling for obstetric care, isolation and loneliness were major barriers to relocation for birth. And finally, unsuitable or inadequate contraception and alcohol. There is underutilisation of contraception in Indigenous communities. Women who are dissatisfied with a particular contraceptive are unaware of alternatives. Some studies reported a link between alcohol consumption and lack of contraception, and also to sexual violence. So what can we draw from all this? We know that socio-cultural, structural, and health system-related factors contribute to Indigenous Australian women's social vulnerability. Reproductive coercion, unbalanced power dynamics, intimate partner violence, and reputational damage undermine women's reproductive autonomy and sexual agency. Sexual education needs to be in an accessible language and format, should start earlier in schooling years, and needs to be done with interventions that increase women's self-efficacy and reduce gender-based violence. Long-acting reversible contraception, such as intrauterine devices, are inexpensive, covert, require few appointments, and can reduce unintended pregnancies. To the future, there is scope for adopting a strengths-based approach, looking at enablers to sexual health and reproductive autonomy, such as strong female role models and positive relationships with female family members, because the time for gender equality is now.
Hello. My name is Anna Pepperly. I am a recent Master of Social Work graduate from Fordham University in New York, and I am so excited to be speaking to you today about immigrant women's access to sexual and reproductive health. A multitude of federal restrictions within the United States, along with many intersectional factors, have made accessing healthcare difficult for immigrant families. The Guttmacher Institute looked at how implementing the Health Equity and Access Under the Law, or HEAL, Immigrant and Families Act, which has been introduced in the U.S. Congress, would remove legal barriers to coverage and boost eligibility for three particular groups: lawfully present immigrants, DACA recipients, and undocumented immigrants. By striking down these walls, immigrant women improve their ability to obtain critical health services and the information they need. During COVID-19, health services and information may not be available. However, the World Health Organization states that sexual and reproductive health is an essential service. Yet, during pandemics, access to reproductive services can be severely disrupted. The impact is intense. Even a 10% reduction to reproductive services could result in an estimated 15 million unintended pregnancies and 3.3 million unsafe abortions. What can be done? We can prioritize digital access, self-care interventions, and outreach into the community. The Migrant Clinicians Network states that in order to bring about change, we can do the following: allow walk-in appointments and extend care hours past the average workday. Also, incorporate promotoras into the clinical care team. These are bilingual women who have experienced sexual violence and go into their communities to educate and create consciousness around sexual and reproductive health. Also, we can make sure that educational components are culturally appropriate and available in all languages spoken within the community. Thank you.
Hello, my name is Liz Manis, and I obtained my master's in social work from Fordham University in New York City. I represent the IFSW, the International Federation of Social Work at the United Nations, and I am an LGBTQIA ally and will be giving a brief presentation using the 3 articles seen on the screen. LGBTQIA+ sexual education is sexual health for everyone. Sexual health is directly linked to family planning. The first article gives a history of the LGBTQ sexual education in schools in the United States and its challenges. Historically, sexual education has been about preventing pregnancy and STDs as opposed to understanding one's gender and sexuality. In the United States, sexual education from the school is governed by state, and actual content is up to the school district, which becomes hyper-specific to where you live. There are slight differences between what is required and what is permitted, and there are no specific outlines on how it is done. As a result, sexual health education differs from school to school. Religious groups, school board members, parents, and teachers are some of the people who influence sexual education in schools, and lawsuits have occurred in the U.S. to fight diversity in sexual education. The lack of attention given to the LGBTQ population in sexual health classes in schools gives the message that the LGBTQ population are not accepted. This decreases emotional and social well-being, and as a result, there's an increased risk in suicide, homelessness, and high-risk behavior. There are many benefits to including fluidity and sexuality in gender and education. All students have an increased exposure to diversity, and students are able to better understand themselves. The second article is from the perspective of doctors and nurses in British Columbia. Clinicians feel unequipped when working with the LGBTQ population, and the lack of education provided can discourage teens from seeking help. Intervention at the individual and structural level will increase support in both healthcare clinicians and the population in which they serve. At a structural level, there is a lack of training and finances that would address broader issues such as outreach and concrete services. And services would increase community support and cultural competence, which would enable healthcare professionals to create a more comfortable experience for the LGBTQ population. The third article talks about how LGBTQ community educates and shares experiences with one another through the use of libraries and internet. It speaks about the global interactions and the cultural differences, and the internet can be a place for support, anonymity, and connection for people to share. It speaks about how librarians can provide a safe space for education, expression, and community building through books, and some of the barriers that librarians face globally are censorship and poverty. Books show the physical representation of the LGBTQ experience, existence, and expression, and this representation matters. Integrating sexual health education for the LGBTQ community in school will reduce stigma and fear in this community. It will normalize the experience and bring self-acceptance. It is accepting of diversity. LGBTQ sexual education information is needed, and individuals are seeking it on many levels, and this incorporation of LGBTQ sexual education in schools is important for all. Thank you for listening to my presentation.
Hola, my name is Jasmine Marbella Vargas, and I am a Fordham University United Nations intern. I'm currently receiving my Master of Social Work at Fordham University. I am Dominican American, and I'm interested in the topics of global health, education, and gender equality. Today, I will be discussing the implications of poverty in the Dominican Republic with the public health issue of maternal mortality, which is one of the leading causes of death of women in the Dominican Republic. The Dominican Republic, a third world country, is centralized in the Caribbean region. Its main language is Spanish. It's known for tourism. The people are centralized and focused on hospitality and the sweet nature that characterizes Dominicans. Within the context of a humanitarian lens, many humanitarian workers are sent to try to remedy the issue of maternal mortality and morbidity in the Dominican Republic. However, the biggest discrepancy is that the workforce is not adequately skilled, and by that I mean many healthcare workers are sent to the Dominican Republic do not meet the qualified standards of addressing this issue. What must be done from a humanitarian perspective and lens is provide 1, world aid to the Dominican Republic, and 2, skilled labor and trained skilled labor workers to try to remedy this issue of maternal mortality and morbidity in the Dominican Republic. Thank you so much. I look forward to receiving this presentation and delivering it all to you, and I appreciate your presence, and thank you so much.
Greetings to all. I am Maggie Mikhail. I am a New York entrepreneur and lawyer based in the Dominican Republic for the past 20 years. It is an honor to be part of the International Health Awareness Network, EHAN, and this conference. I firmly believe that the empowerment, education, and health of women and girls are crucial to obtaining gender equality and also contributes to a more peaceful world. Therefore, I entirely agree, support, and am very proud of the work of EHAN. I became an EHAN volunteer during my first year at Columbia College and participated in EHAN's Children's Immunization and Health Program in Mundini, Kenya in 1989. Later, I did research for EHAN on the tremendous effects of female genital mutilation in girls and certain African countries. For approximately 20 years, I have been on EHAN's advisory board. In this capacity, in March 2016, I cooperated so that EHAN, with the generous support of its board members, Dr. Sarush Roshan, Dr. Gabriel Casper, as well as the Rotary Australia World Community Service and the DAC Foundation, could donate a portable ultrasound unit, transvaginal probe, and sonotrack fetal Doppler to Clínica La Familia in La Romana province of the Dominican Republic. Clínica La Familia's Adolescence, Maternal, and Infant module provides family planning, HIV rapid test with pre and post counseling, pregnancy test, prenatal consultation, including treatment for HIV vertical transmission prevention, psychological consultation, gynecological consultation, pediatric consultation, boys clinic, and sexual and reproductive education. This module now operates from the Francisco Gonzalo Public Hospital. Currently, the donated equipment serve the 2,000 member community of the Cucama Rural Public Clinic, also in the province of La Romana, in alliance with Clínica La Familia. This rural clinic is able to provide primary health services to a previously underserved poor community where the mere cost of transportation to the center of the nearest town is simply prohibitive for its members. The outreach, monitoring, follow-up, and education services have immediately impacted the well-being of this community. We will first hear from Ms. Mina Halpern, Executive Director of Clínica La Familia, and subsequently from Dr. Wendy Galvez of the Cucamama Rural Clinic. The quality of treatment for patients of both clinics was dramatically improved through this generous donation. Thank you. Thank you very much.
Good morning. I'm Mina Halpern. I am the Executive Director of Clínica de Familia La Romana, and it's a pleasure to be able to thank EHAN for the wonderful donation of a portable ultrasound machine, which we've used for many years at our teen clinic. We work on providing services to adolescents, reproductive healthcare services, including prenatal care, and so that's where we've been able to use our ultrasound machine to be able to see the health of their babies and to provide quality care to a population that oftentimes is discriminated against. We also work really hard on pregnancy prevention. So with those teens who are pregnant, we provide them with a lot of education and support so that they can have a healthy baby, but also so that they can prevent future unplanned pregnancies. We go into schools and do comprehensive sex education, and we're just so appreciative of EHAN for helping to support this really important work that we're doing in the Eastern Dominican Republic. Thank you so much.
Hola, muy buen día. Mi nombre es Wendy Galvez. Soy la doctora encargada del Centro de Atención Primaria Cucama en La Romana, República Dominicana. Estamos tratando de dar un servicio oportuno a la comunidad y por ello agradecemos la donación que nos hizo Clínica de Familia.
Thanks. I'd like to thank all the speakers. We are very, very, very behind time. So I've asked Anna if she could just divert the questions over to Rosemary Ogu, because Eleanor and Rosemary came on the webinar at midnight, so it's now 3 in the morning. So I think for their really big effort, she at least deserves some questions, and we want to know what's going on in Nigeria. We really do. So Anna, do you mind just asking your questions to Rosemary?
Absolutely. Rosemary, can you hear me?
Yes, and I can hear you.
Fantastic. Thank you so much for being online. It must be some very absurd hour of the morning for you. So firstly, I just wanted to ask if you could tell us a little bit about your hospital and how many deliveries you do in a year.
Thank you. My hospital is Extreme Hospital, so we have medical students as well. We do about 2,000 deliveries per year. We used to do about 4,000. Now we do 2,000 deliveries a year.
Wow, that's fantastic. And from your bio, we can see that you work with the WHO. So could you tell us a little bit more about this work?
We do quite a number of things with WHO, all aimed at improving maternal health and women's health. And so the last big collaboration that we did with the WHO was the Safe Childbirth Checklist for improving maternal health and preventing maternal mortality. So Safe Childbirth Checklist, that's the last one that we did.
And how can we support your efforts in the hospital?
Wow, thank you. You know, right now we have a lot of stockouts because women are unable to pay for things. And so if we have people support, fund a project, make donations, anesthetic pack, delivery packs, that would really be nice. Anyone who wants to support can reach us through Professor Casper. Thank you.
Thank you, Rosemary.